Welcome to this essential guide on understanding and managing postpartum hemorrhage. As a woman or a healthcare professional, it's crucial to be informed about postpartum hemorrhage. Today we will explore the definition, etiology and pathophysiology, risk factors, clinical features, differential diagnosis, investigations and management of postpartum hemorrhage. Postpartum hemorrhage, PPH, is defined as a blood loss of 500 milliliters or more following childbirth. PPH can be categorized according to the volume of blood loss and timing of the hemorrhage. Minor PPH, 500 to 1,000 milliliters blood loss without clinical signs of shock. Major PPH, 1,000 milliliters blood loss or 1,000 milliliters visible blood loss with clinical signs of shock. Primary PPH, PPH occurring within 24 hours of delivery. Secondary PPH, PPH occurring from 24 hours up to 12 weeks post-delivery. Postpartum hemorrhage is one of the leading direct causes of maternal mortality in the UK. It is important to understand the causes of PPH and have an approach to clinical assessment and management of this common obstetric emergency. The causes of primary PPH are often referred to as the 4 T's. Tone, an atonic, not well contracted, uterus accounts for up to 80% of cases of primary PPH. Trauma, injury as a result of childbirth, most commonly perineal tears, lacerations and/or episiotomy. Tissue, retained products of conception, e.g. retained placenta. Thrombin, underlying disorders of clotting, e.g. hemophilia or use of low molecular weight heparin. Secondary PPH is usually due to one of two causes: endometritis, infection of the endometrium, retained products of conception. Risk factors for PPH include previous PPH, particularly when the cause was atony, grand multiparity, overdistension of the uterus, polyhydramnios, macrosomia, multiple pregnancy, clotting disorders, antepartum hemorrhage, placenta previa, prolonged labor, operative birth or caesarean section, induction of labor. The main clinical feature of PPH is heavy bleeding from the vagina or directly from the uterus at caesarean section. There may also be signs of hemodynamic instability, such as tachycardia, hypotension, prolonged capillary refill time, or cool peripheries. Other clinical features are dependent on the underlying cause of the hemorrhage. Primary PPH tone. The uterus may feel enlarged, soft, or boggy. Trauma. There may be visible lacerations or tears on vaginal examination. Tissue. On examination of the placental tissue or membranes may be incomplete. The most common cause of secondary PPH is endometritis, which may present with the following clinical features. Signs of sepsis, tachycardia, hypotension and pyrexia. The uterus may be tender or bulky on palpation. On speculum examination, the cervical os may be open and foul-smelling discharge may be present. PPH is a clinical diagnosis based on signs and symptoms. Bedside investigations. All patients with PPH should have their vital signs taken as part of their clinical assessment and management. The following blood tests should be taken as part of the management of primary PPH. Full blood count to assess for anemia. Coagulation screen. Heavy bleeding can lead to disordered clotting. Group and save and cross-match to enable transfusion of cross-matched blood. Urea and electrolytes and liver function tests to assess baseline function. The management of secondary PPH includes screening for sepsis, as this may develop secondary to endometritis. Sepsis screening involves the following additional investigations. Blood cultures, to establish if there is bacteremia. Blood tests, lactate and CRP. High vaginal swabs, to send for culture to inform later antibiotic choice. Pelvic ultrasound scan, to look for evidence of retained products of conception. Minimizing risk, anemia. All pregnant women should have a full blood count carried out at booking and at 28 weeks gestation. Antenatal anemia, if microcytic or normocytic, should be treated with iron supplementation and monitored for improvement. Active management of the third stage of labor. The third stage of labor refers to the time after the baby is delivered until delivery of the placenta and membranes. This stage can be managed passively or actively, depending on maternal preference. However, it is important that women are informed of the increased risk of postpartum hemorrhage if they opt for passive management. Active management. Use of uterotonic drugs, e.g. oxytocin or symptometrine or oxytocin ergometrine combined. Deferred clamping and cutting of the cord. Controlled cord traction to deliver the placenta. Passive management. No routine use of uterotonic drugs. No clamping of the cord until pulsation has stopped. Delivery of the placenta by maternal effort. For women who already have risk factors for PPH, active management is strongly recommended. All women should be offered prophylactic uterotonics as part of the routine management of the third stage to reduce the risk of PPH. Postpartum hemorrhage is an obstetric emergency which should be managed by a senior obstetrician with support from anesthetic and midwifery teams. An ABCDE approach should be adopted when managing patients with PPH. Airway. Consider airway adjuncts and call for anesthetic support if there is an airway problem. Breathing. Assess respiratory rate and oxygen saturations, as well as performing auscultation of the chest. Consider supplemental oxygen. Circulation. Assess for signs of hemodynamic instability, heart rate, blood pressure, central capillary refill time. Estimate blood loss and assess for ongoing bleeding. Establish intravenous access with 2 wide-bore cannulas and take bloods. Consider using point-of-care testing to estimate hemoglobin level, e.g. HemoQ. Administer warmed crystalloid solution until blood products are available. Insert a urinary catheter to monitor urine output and to prepare for possible further intervention, e.g. C-section. Estimating blood loss from PPH can be challenging. Weighing swabs can help with assessing the volume of blood loss. Most hospitals will have a major obstetric hemorrhage protocol, which should be activated if there is 1,000 milliliter blood loss with ongoing bleeding. The purpose of the protocol is to minimize delays in accessing blood products. Further treatment depends on the suspected underlying cause of PPH. Tone atony is the most common cause of PPH. Management options for PPH secondary to atony include pharmacological, uterotonic drugs, oxytocin, ergometrine, sintometrine, oxytocin ergometrine, carboprost, misoprostol. Mechanical. Rub the uterine fundus to stimulate contractions and or bimanual compression, one hand in the vagina with the other hand compressing the uterine fundus. Surgical. Common measures include intrauterine balloon tamponade and hemostatic sutures. Hysterectomy is rare, but should be considered in life-threatening hemorrhage where other measures have failed. The choice of pharmacological treatments depends on those given as prophylaxis in the third stage of labor. Trauma. Any perineal tears should be repaired by an experienced obstetrician or midwife. Tissue. If the placenta is retained and there is ongoing bleeding, it may be necessary to go to theatre for manual removal of the placenta-retained tissues. Thrombin. Consider administration of tranexamic acid. Consider agents such as vitamin K in discussion with hematology, if appropriate. Liaise with hematology with regards to blood products. As a guide, prior to blood results being available, it is reasonable to assume that fresh frozen plasma will need to be given after every 4 units of red blood cells. Secondary PPH is usually caused by endometritis and/or retained products of conception. Therefore, management is similar to that of any infection sepsis. Consider a pelvic ultrasound scan if retained products are suspected. Surgical evacuation of retained products of conception may be necessary. A blood transfusion should be considered if hemoglobin is below 80 grams per liter and the patient is symptomatic of anemia. Consider the best place for care following a PPH, which may be critical care if invasive monitoring is required. Postpartum hemorrhage can be incredibly traumatic for the woman and her birthing partner, so it is important to debrief, explaining what happened, and discussing any implications for future pregnancies. Ensure that documentation is clear, with accurate timings of each step taken. Complications of PPH include anemia, possibly requiring blood transfusion, hypovolemic shock, leading to organ dysfunction such as acute kidney injury, post-traumatic stress disorder, hysterectomy, disseminated intravascular coagulation, Sheehan's syndrome, postpartum pituitary gland necrosis, death. Thank you for joining us in this educational journey on understanding postpartum hemorrhage. Stay informed and take proactive steps to safeguard your health.